Good evening and welcome to this international webinar at Believers Church Medical College and Hospital. This is our 45th webinar and today's subject is ophthalmology. And to talk about ophthalmic emergencies, we have our international faculty, Dr. Ramesh Raghavendran Sivaraj sir. He is the consultant ophthalmologist, research lead and deputy clinical services lead at the University Hospitals NHS Foundation Trust, Birmingham, UK. After completing his medical education from the prestigious Madras Medical College, he went on to train in ophthalmology at Madurai Medical College in India and trained in vitreoretinal surgery and cataract microsurgery from the famed Shankar Nethralaya. After his retinal fellowship at the Moorfields Eye Hospital in the UK, he also was the retinal ASTO fellow at the Birmingham and Midlands Eye Hospital in UK. He went on to work at Heart of England NHS Foundation Trust as the clinical lead in ophthalmology and clinical lead in diabetic retinopathy. With more than 20 international publications, 15 poster presentations, and 7 odd invited lectures, and being the principal investigator in 4 clinical trials and co-investigator in 4 more trials. Sir is a distinguished faculty and he is also member of a number of associations like the British Medical Association and American Academy of Ophthalmology. Ramesh sir, it's a great privilege to have you as our invited international guest speaker. Thank you so much for joining us. Welcome, sir.
My privilege. Thank you so much for the lovely introduction, Jacob.
Thank you, sir. And to moderate our session, we have the professor and head of ophthalmology at Believers Church Medical College and Hospital, Dr. Satish Thomas, sir. Sir is the previous head of ophthalmology at CMC Ludhiana, and he has trained in the best ophthalmic centers in India and abroad, namely the Dr. Rajendra Prasad Center for Ophthalmic Sciences in AIIMS, Shankar Nethralaya, Royal Alexandria Children's Hospital in Sydney, and more. He's one of the first ophthalmologists to be trained under the prestigious Orbis Pediatric Ophthalmology and Strabismus Fellowship in India, and under arguably the best pediatric ophthalmologist. He set up Orbis Pediatric Ophthalmic Unit at CMC Ludhiana and was previously the head there too, with more than 9 international and 10 national peer-reviewed articles. He is also an invited speaker at national conferences on various compelling topics. He's an undergraduate and postgraduate university examiner and also thesis guide for postgraduate students. He is an excellent clinician and an amazing leader. Satish sir, it's a great honor to have you to moderate this session. And we are extremely grateful that after traveling for so many hours and just landing in station, you've taken up this particular responsibility. Thank you, sir. Over to you for the overview and handing over. Satish, sir.
Thank you, Jacob, for those kind words. We're really privileged to have Dr. Ramesh do this talk for us. And he's chosen a wonderful topic on ophthalmic emergencies, mainly because this group is a homogeneous group. And I'm sure you'll find this topic extremely useful because for many of you students and non-ophthalmologists, it is the ophthalmic emergencies that will be your first exposure to ophthalmology. When you're interns, when you're residents in the casualty, and like that. So ophthalmic emergencies are again so important because as in most emergencies, the permanent outcome would depend upon what you do in those few minutes that are available to you. And so let's listen to one of the experts talk on this topic. And I would request you, if you have questions, to just put it up in the chat box. At the end of the talk, I will take them up and we can discuss it with our esteemed speaker. So over to you, Dr. Ramesh.
Thank you, Professor Thomas. Let me just start by sharing the screen. I hope you can all see the screen. First of all, many thanks to Professor Jesiran for his kind introduction and for inviting me to give this talk, and also to Professor Thomas as well. I'm really privileged to have shared some of our training areas. We trained in the same places in India at some point. Some of you might know that I'm from Southern India, and it's a great honor and privilege to connect back with our roots. And thank you again for this lovely opportunity. I'm going to try and use this opportunity to talk about ophthalmic emergencies. And as one would imagine, let me just move the slides across. So we have multiple types of emergencies which can have, and I'm going to try and classify this as those related to trauma, which most of us can see when we will start working in casualties and so on, and also some of the medical emergencies which one would be exposed to. So sorry to show you a shocking image, but this is to make sure that all of you know what we're talking about. As you can see, this is a bottle which has gone right into the eye. And this is unfortunately not a very uncommon thing. And it happens around Fridays and Saturdays when people finish off a hard week's worth of work. This picture was taken in Germany, as you can see from the writing, but we do see things like that happening over the weekends here in the UK as well. I wanted to go into a bit of history about the nature of injuries. And as you can imagine, in the industrial area in the first part of the 20th century, one would expect most of the injuries to be work-related, with 30% of them having intraocular foreign bodies, which results in metal chips from grinding and from hammering, etc. And then the World Wars I and II took over, and most of the injuries which came onto the eyes were related to explosives and shrapnel, as one would expect. Once we went back into an era of peace, then we decided that we needed to drive very fast cars, and there wasn't a seatbelt law in place then. So as one would expect, quite a lot of eye injuries were related to windscreen injuries, etc. Of late, when now the seatbelt law has been imposed in most countries, most of the injuries are related to sports and recreational activities. Ice hockey and racket sports are especially a little more dangerous. And obviously, people have now taken on hobbies such as do-it-yourself jobs, trying to redecorate their houses, building shelves, and doing a lot of gardening, which has also resulted in significant injuries more often nowadays, particularly in the 2000s. So why is it important for us to look at ophthalmic emergencies? As a doctor, we need to realize that in a country which probably has about 60 million, in the United Kingdom, there are about 4,500 admissions per year in the UK alone, just for significant eye-related problems, with about 250 of them losing their vision. And it's shocking to know that 50% of these injuries happen at home. And this is related to the DIY and gardening injuries, which we were talking about. So what is the nature of the injury? Most of these injuries are blunt injuries. So there's no actual perforation of the eyeball, but 20% of these injuries can be a perforating eye injury, which is obviously more dangerous, with about 1% of them having an intraocular foreign body, which needs to be dealt with quite soon. So let's start with trauma. So I have a division of blunt trauma and perforating injuries. So if you look at blunt trauma, what are the things that can happen? Blunt trauma can affect all the ocular structures, starting with the lid. It can result in a tear in the lid. It can cause a large hematoma in the orbital structures. You can have a blowout fracture of the orbit. You can have some bleeding within the eye, the force can be enough to rupture the sphincter. The pupil might be misshapen after then. Sometimes the root of the iris can be torn away. And if the velocity is fast enough, then you can have problems in the back of the eye, the posterior segment, causing a retinal detachment and sometimes a choroidal rupture. You can have a ruptured globe if the velocity is quite a bit, and you can have an intraocular foreign body. And we'll also discuss about chemical burns and an unfortunate group of injuries called as non-accidental injuries a little later in this talk. So what does happen in a blunt injury? It's usually because of mechanical waves which are transmitted through the globe. And as you can see, the velocity causes distortion of almost all the ocular structures, and therefore every structure of the eyeball, including the eyelids in the front, can be affected. So let's look at lid laceration. So when you have a patient who presents with a lid laceration, what are the first things which you need to do? Obviously, the patient is going to be in quite a lot of pain, but it is quite important to make an effort to make sure that the globe integrity is maintained. In terms of management, if you have a patient whose laceration is crossing the lid margin, involves the medial canthus or the lacrimal apparatus, the tear draining apparatus, or involves the levator muscles, which causes the eyelid elevation, these patients should be seen by a specialist because they will need some extra work under the microscope. But if you have any other lid lacerations, it's quite possible for a person who has some microsurgical training to repair that with a 6-ohm monofilament suture. But always do remember, you need to check what the tetanus status of the patient is. Here is an example of a young lad who managed to have a lid laceration along the medial end of his eye. It looks quite ghastly, and this is not something which we would expect to be repaired in the eye casualty. Obviously, the canalicus is affected as well. So this patient ended up having suturing done under the microscope by an ophthalmologist. And it's very difficult to restore the lacrimal integrity. In other words, to make sure that the canalicus is not affected. And oftentimes these patients end up with a watery eye. There's a more complex surgery which will be needed at a later date. Let's next look at periorbital hematomas. These hematomas are caused by direct knock injury, direct blow to the orbital region. When you have these patients, you need to make sure that you check for other ocular damage, make sure that the eye in itself is not damaged. You also look for a flow fracture. You look to see if there's a high femur, and you try and attempt to make a fundal examination, which might not be possible in the initial stages, but every attempt should be made to see if you can look into the fundus. There's one thing which is quite important. If you're not able to complete your ocular or an orbital examination, at least make sure that you can get a quick glimpse of how the pupil's reacting, because if the pupil's reacting nice and briskly, then you can be slightly reassured that there's perhaps not severe injury to the eye itself or the optic nerve. If you suspect there is a bony injury, then please ask for at least an X-ray. You'll find that applying cold compresses and giving the patient some analgesia, and maybe perhaps in an hour or so, you might find that examination is a bit easier and the patient is a bit more cooperative. So here is an example of a young lad who was involved in a brawl in a pub over the weekend again. And you can see that there's a large bluish swelling with the lid completely shut. So we don't really know what's happening to the eyeball here. And this is where the cold compress might help. And you can take a guess as to what might have caused the fight. You can see how his pupils are dilated. So perhaps a bit too much of ETOH. Let's look at features of blowout fractures. So blowout fractures are caused by direct blow to the orbital region. Patients usually present with orbital pain and complain of pain when they're trying to move their eyes around. They oftentimes report diplopia, which is double vision. And they say that they cannot feel around the cheek, paresthesia over the maxilla. When you examine these patients, you find that one eyeball is more prominent than the other, which we call as enophthalmos. And when you try and ask them to move their eyes around, you find that there's quite a bit of restriction of the eye movements. If you feel around the orbital rim, you'll find that it's quite tender for the patient, and oftentimes you'll be able to elicit surgical emphysema, so which is crepitus. As you run your finger along, you find that you can send some crepitus there. And if you can just check the sensation, you'll find that the sensation over the second trigeminal division would be reduced as compared to the other side. So what do you do with these patients? You need to get them to have an X-ray and obviously refer them to the ophthalmology and the MaxFax team, because we need to plan surgical procedures for them to make sure that we restore the eye back to its normalcy. So here is an example of a patient with a blowout fracture. If you were sitting in a lecture room, I would ask you which eye do you think is affected, but obviously because you're all muted, let me answer that question. So here we have a lad who's looking straight into us with no problems at all. And when the patient's looking up, you can see that the left eye is going up, but the right eye stays there. And similarly, so when the patient's looking down, the right eye has not made any significant excursions. So you can assume that it's the right eye which is affected on this side. This is obviously a bit, there's been some time between the actual injury, so you can't see any acute signs there. And this is a typical feature of a blowout fracture, which has caused an entrapment of the muscle, which is preventing it from going up or coming down. Here is another example of a slightly more acute case. And here you can see that the patient's looking straight ahead. There's nothing much available except for perhaps a little bit of divergent squint, which can be quite normal. But when the patient's looking up, you can see that the right globe is really not moving up at all. One other thing to notice, which can be, if the doctor who's seen this patient and assessed this patient has not really dilated the pupil, and you have a situation like this with one small pupil and another dilated pupil, that should raise alarm bells, and this patient should be blue lighted and rushed to an ophthalmologist straight away. But in this particular case, this patient was dilated to make sure that there was no retinal problems. And this is a very interesting sign which you can elicit when you are doing a clinical examination if a patient has a possible blowout fracture. So if you look at the eyeballs, either from the perspective of the patient's mouth, or if you look at it from just above the forehead by asking them to tilt the head back, and you see that one globe is suppressed as compared to the other one, this is called as a Nafziger sign, and it's quite an important sign to look out for when you suspect trauma. Here is an imaging picture showing that the orbital fat has prolapsed into the maxillary antrum, and you can actually see this on an X-ray as well, and this is usually called as a teardrop sign. And when you get an X-ray of a patient with an injury, and if you notice that the maxillary antrum is filled with something which does look like a teardrop, then you should suspect the patient has a blowout fracture. So let's move on to hyphema. As you all know, hyphema means blood in the front of the eye, in the anterior chamber. And the usual causes for hyphema is a direct blow to the eye. And as one would expect, if there's blood in the eye, the vision is going to be quite blurred. There's usually a bit of associated inflammation as well. So the patient's going to complain of watering and difficulty in facing bright light. They've got the hand in front of their eye, etc. And when you examine the eye, it's quite obvious that there's some blood in the anterior chamber. So when you have a patient with hyphema, again, you should make sure that there is no other severe damage. For example, the globe is intact. You need to get this patient to see an ophthalmologist straight away. Patients usually admitted and put on bed rest because the hyphema, once the blood clots and contracts, there's a possibility of a second bleed. These patients need to be started on a topical steroid regimen. And you have to check their eye pressures as well. There are several ways of checking the eye pressures now with little gadgets which are quite easy. And most of the eye casualties or the regular casualties might also have them. So if you check and find the eye pressures are high, then you need to start them on some drops, perhaps to reduce the eye pressures. As I said to you before, once the hyphema contracts, you can have a secondary bleed, which can actually be much more dangerous. And if the bleed covers more than 2/3 of the anterior chamber, these need to be evacuated surgically. It's probably not very significant in India as such, but here in this country, we look for sickle cell disease in patients who are of African Caribbean origin or of mixed parentage, because Those patients do quite badly when they have a bleed in the eye. There might be an impact of thalassemia traits as well in patients who have bleeding into the anterior segment. So it's worth asking that question when you have a patient with high FEMA. So here is an example of a patient with layered blood within the eye. This is a classical picture of a patient with high FEMA. And you can see the patient also has a large subconjunctival hemorrhage next to it. So let's move on to the other things which can affect the iris, blunt trauma which can affect the iris. As you can see, the pupil is irregular along this area. So this is because the sphincter has been ruptured in various places, which has caused the pupil to become irregular. Here we have the iris root, which has taken significant trauma and has come clean, has torn off from its root. And this is called as iridodialysis. So let's look at some of the features of the ruptured globe next. So it's usually because of a significant velocity injury. It can either be blunt or sharp. Now, obviously, sharp might be a lesser velocity than a blunt injury. Symptoms can include very severe pain and loss of vision. When you examine these patients, you'll find that there's quite a lot of blood under the conjunctiva, and you might notice a full thickness scleral or a corneal laceration with prolapse of intraocular contents, including the iris and the choroid. So what do you do with these patients? Obviously, the first thing which you need to do is to make sure that they have tetanus prophylaxis. Try and get an X-ray to find out if the patient has a foreign body in the eye. Get a plastic shield to cover the eye, because inadvertently sometimes patients might get their hands to their eyes, and you don't really want any force, and it will be ideal that you don't really put a pad over the eye, rather get a plastic shield to stop any direct pressure. These patients need to be referred urgently to the ophthalmologist. When the ophthalmologist sees the patients, we try and do things in two steps. First is to restore the integrity of the globe, which means that if there is a scleral laceration or a corneal laceration, we repair that. And the second procedure would probably be to try and attempt to restore function. Here is another shocking picture, but you'll be pleased to know that the gentleman with the yellow jersey didn't suffer any long-standing damage. Thankfully, we don't play too much of rugby in India, I think. But there's still several other sports which can have these type of things happening. So we all need to have a look out for them. Here is an example of a scleral laceration. So what we are actually seeing here is this is the cornea, as you can see. So the sclera has ruptured here, and you can see that the choroid has come out as well. You can see the shiny gel-like thing over here is the vitreous. So the vitreous has actually exited the eye. So this is a rather nasty injury, and it'd be quite difficult to get this globe restored and its integrity maintained. And I suspect this patient would have ended up with quite a few complications. But this is how it looks when you have a scleral laceration. Here is an example of a rupture along the limbus, and you can see the pupil is misshapen and the iris is prolapsed outside. So again, this patient would be a surgical emergency where we try and get some povidone eye drops into the eye. In some instances, if the iris has been incarcerated for too long and exposed, it might be an idea to just remove the iris and suture the wound. But if it's quite a fresh injury, and we can sometimes restore the iris integrity by pushing it in gently and suturing the edge. This is an example of a patient who has a corneal laceration. Now, if just one quick look without major light or slit lamp examination might not give you that many clues, but you can see that there's a white mark over here in the cornea, and that's the area where the cornea has been perforated. And you can also see that there's some whitening of the natural lens causing a traumatic cataract. Another shortened picture. This is not something which you tend to see a lot, but that's a literal nail in the eye. So we'll move on to intraocular foreign bodies. It's quite important to try and find out what type of foreign body injury has happened. And the reason why we want to do this is because we know that foreign bodies can either be inert or can be toxic. So you can have things like gold, platinum, etc., silver, which don't cause too much of reaction. And therefore, in some circumstances, it's not urgent to get them out, and some of these foreign bodies can be left within the eye as well, because they don't cause too much damage unless they're affecting the structure of the eye, like for example, causing a problem with the retina. Whereas there are other objects such as the organic objects such as thorn, twigs, maybe wood, soil, and even a hair follicle, and metallic substances like copper, which can react and cause significant problems, and these need to be removed as soon as possible. And in the middle, you have things like lead, aluminum, and iron. So how do intraocular foreign bodies get into the eye? Obviously, it has to be a high velocity impact. Patients can present with a plethora of either very mild pain, or they can complain of severe pain as well. And if it does not involve the actual visual axis, the patient's vision might not be affected. And signs can be quite minimal. It's important to have a proper look at these patients, and the entry site might not be quite obvious. As we see in patients, if they have a large subconjunctival hemorrhage, you might not actually be able to see the scleral entry site. So what do you do in terms of management? You get these patients to have an X-ray, and again refer them on to an ophthalmologist who will probably get them started on systemic antibiotics, the broad spectrum, something like ciprofloxacin, and consider vitrectomy surgery once they've determined where the foreign body is. So I just wanted to show you an example of something which can be quite difficult to see. So here you can see the patient has a few iris freckles. So this can be quite easily mistaken as a freckle, isn't it? But this is actually a full thickness hole in the iris. And you can see that the lens has started to get a bit cataractous as well. So when you look into the retina, you can see that the foreign body has gone all the way through the iris, through the lens, and is sitting on the retina. So this patient will obviously need to have an operation to get this foreign body out. And again, I mean, there are fashion fads like this, and maybe in the early 2000s, we had quite a lot of young patients coming in with small little fancy things implanted under the conjunctiva for fashion reasons, and some of them developed severe inflammatory reactions following this. Thankfully, this fad has fallen off, and we don't see too many of these patients nowadays. So let's move on to chemical burns. So chemical burns is something which almost all of us doctors will be exposed to. Even if you're not an ophthalmologist, it's likely that you will have to take care of some patients who've had a chemical burn. So obviously they're of either the alkaline, or the acidic types. And we do need to remember, it's important to try and find out what exactly splashed into their eyes and how much of it splashed into their eyes. So why do we need to know this? Because the alkalis, they penetrate the structures quite rapidly, and therefore they can cause quite a lot more damage than acids. And acids, what they tend to do is, as soon as they come in contact with the surface, they tend to aggregate with the proteins, which then forms a barrier stopping influx of acid. But nevertheless, if the acid is of a very low pH, then it can still get into the eye. The symptoms, obviously the patient will be in agony with a lot of pain, redness, and photophobia, and the vision will also be significantly blurred. When you examine these patients, obviously on a slit lamp, you'll find that they have lots of conjunctival injection, you'll have epithelial loss in the cornea, you can have swollen conjunctiva, chemosis, and sometimes the blood supply in the limbal area, which is the area between the cornea and the sclera, can be significantly affected, and that is usually a very bad prognostic sign. When you examine these corneas, they tend to be cloudy, and you can also have intraocular inflammation, which is called as uveitis. What do you do with these patients? First thing you need to do is to get these patients to have some topical anesthetic drops, and you get them onto a couch and start irrigating them with normal saline. And this should carry on for at least 30 minutes. You can use a pH strip to try and check to see if the pH has become neutral. Sometimes as you're flushing the eye out and you're testing the pH straight away, it might seem as if the pH is neutral, but it's important to do the test after a few minutes, and you'll find that it gets acidic or alkaline again. If that is the case, it's quite important to continue with irrigation as much as you can. And that's a critical bit when you manage a patient with a chemical burn. It's again important to get on the phone and speak to an ophthalmologist to get this patient seen. And once they come into the ophthalmology department, we assess the extent of the burn, and depending on what it is, they might need in addition to the topical and oral vitamin C and drops, which include cycloplegia. So cycloplegia is when you have inflammation within the eye, the cyclical muscle inside the eye goes into spasm, which causes the pain. So by giving things like cyclopentolate or atropine, we can paralyze the muscle, and that relieves the pain to a certain extent, but it also dilates the pupil. We start these patients on topical steroids and some antibiotics as well. So some of these patients with more severe injuries, as in this, you'll see in the next slides, would probably necessarily need to have some surgical procedures, etc. So this is just a list of things which all probably come across in our household really. So draining, cleaning fluid, and you can see how the pH is quite extreme amongst all of these, and battery fluid and lavatory cleaners, etc., where the pH is down to 1. So they can have a significant and serious impact. And I don't think most people who tend to do these jobs at home bother to wear eye protection, and it's quite critical, you know, particularly when you see people who even working in the hospital and so on, cleaning using substances like this, should be given some protective goggles to make sure that they don't have any serious injuries later on. Here is an example of an alkali burn, and you can see that we talked about corneal clouding, and obviously you can see that the cornea is extremely clouded. You can see that the blood vessels are all quite congested around here, but they're all blanched up here. Now this is generally a very bad sign. So when you have blanching of the conjunctival blood vessels with ischemia of the limbus, as you can see here, this just means that this eye has been knocked out by the alkali, and oftentimes to restore any integrity of this sort of eye is going to be very difficult. As I said to you, these patients might need things like limbal stem cell grafts and possibly even an amniotic membrane graft at a later stage. Let's move on to a very disturbing thing, non-accidental injuries, and I did talk to you about non-accidental injuries briefly as I was
so what is itis? What is
Please mute your mic.
Oh, no.
Yeah, so I thought that was a question. Never mind. So going on to non-accidental injuries, this is quite a serious problem, and most of us would not want to accept it because it's quite an unnatural thing. 35% of serious eye injuries happen in children under the age of 12. And here in the UK, 4% of children attending the eye casualty have been abused in some way or form, which is shocking, isn't it? Unfortunately, most of the children who are affected with these sort of non-accidental injuries are under 3 years of age, and obviously that is because they are the ones who can't really complain. And parents, they tend to be from a single parents who are from a poor socioeconomic status, and they themselves have been abused, and they unfortunately carry it on to the next generation. So what is the mechanism of these injuries? Usually it's shaking the baby, and it's called shaken baby syndrome as well, as you know. So the hallmark of the non-accidental injuries is that the patient has different stages of healing. So when we're looking at the eye itself, one of the things which happens when you shake a baby vigorously is that they develop hemorrhages in the retina, in addition to other injuries to structures like the cornea, etc. But when you examine these patients, you find that they have retinal hemorrhages at various stages of healing. I'll show you a picture in a minute. So what are the consequences of non-accidental injuries? 15% of these children will end up having permanent visual physical problems. And as you would expect, most of these children will probably have 100% of them will have emotional problems for the rest of their life. So it's a very unfortunate circumstance. In my line of work, I'm asked to examine children who have been admitted with suspicion of non-accidental injuries. It's a very solemn job. We have a way of recording what's happening with these children so that it's documented, because this information is usually presented in the court, etc. So here is a picture of what we tend to see in patients with this is a small child's eye, believe it or not, and you can see that there is a very fresh vitreous hemorrhage over here, or a pre-retinal hemorrhage. there are some other hemorrhages. So you can see a duller hemorrhage over here, which is probably a more chronic one. And you can see another hemorrhage, which is probably of a slightly different age as compared to this one and this one. So when you have hemorrhages which are fresh, not that fresh and old, then you should suspect the possibility of a non-accidental injury. Obviously, that very rarely there are other things like bleeding diathesis which can cause these type of problems, but nevertheless, they should be first on your list. You got to rule this out before anything else. Right, so that finishes the emergencies related, ophthalmic emergencies related to trauma. Now let's move on to more of the medical emergencies. So I've clubbed them into 10 little groups to give a little bit of continuity. The first group which we'll be discussing about will be infections of the eye. So you can have orbital cellulitis, you can have infections of the cornea, which is called as keratitis, and you can have endophthalmitis, which is a severe infection of the whole eyeball. Then we have autoimmune situations which can cause the cornea to melt, and you can also cause things like inflammation in the front of the eye and sometimes in the back of the eye as well. Then you've got structural issues such as an acute angle closure glaucoma and retinal attachment, and manifestation of systemic problems within the eye, which includes arterial occlusion, etc. And then finally, we'll look at the eye movement disorders. So let's look at orbital cellulitis. What does orbital cellulitis mean? So you have a structure called as the orbital septum, and anything which an infection and inflammation which happens behind the orbital septum is termed as orbital cellulitis. So if you have an inflammation or an infection anterior to the orbital septum, it's called as pre-septal cellulitis, and in an adult it is not that severe as in children. So what is the cause for the orbital cellulitis? Is usually an infection which spreads from neighboring structures like air sinuses, etc. So the patients can present with frontal headaches, they can have fever, they can have rigor, and so they report diplopia and sometimes loss of vision if the condition is uncontrolled for long enough. The patients, when you check, they have a temperature, they have lid swelling, the whole eyeball is proptosed. There's quite a lot of inflammation around the eye. There's limitation of the eye movements, and sometimes you can have optic nerve compression, which makes it an emergency. If untreated or if not managed properly, these things can result in blindness, and sometimes the infection can spread intracranially, causing an abscess. So we need to consider this as a potentially life-threatening condition. Therefore, these patients need to be admitted for high-dose intravenous antibiotics. You do an urgent CT scan to make sure that the infection is limited just into the orbit and is not spreading into the brain. You also do a full blood count and a blood culture before you start the antibiotics to confirm what exactly you're dealing with. And most often you need to get an ENT surgeon to have a look as well, because the infection usually spreads from the sinuses. So here is an example of a young child with the orbital cellulitis. So here you can see that there's quite a bit of a swollen lid, but we don't quite know whether the infection has spread behind or not. So when you have a situation in a young child where examination is probably not going to be that easy, you need to assume that they have orbital cellulitis and you admit them and treat them with antibiotics. And I'll ask Professor Thomas to confirm this when I finish my talk. And you can also have situations like this in perhaps younger adults as well. And this is a type 1 diabetic, and you can see that there's necrosis of the skin tissue as well, and rather severe inflammation and infection around the eye. And you can see how the orbital cellulitis, when you do a scan, you can see how the whole of the orbit has become a bit grainy, and you can see that the infection has spread from the sinus next to it. So this sinus has been the cause for the problem spilling into the orbit here. So let's move on to corneal ulcers, which are called as microbial keratitis. So microbial keratitis, which is an infection of the cornea, can be caused by gram-positive, gram-negative organisms, as you all know. And it can actually happen secondary to an injury, which can be because of a foreign body, maybe people using contact lenses who leave it for long enough. And if patients had some sort of surgery, whether there's a loose suture, etc., or if they have corneal anesthesia because of any other reason. Patients can present with pain, redness, discharge from the eyes, and photosensitivity, and obviously the vision will be affected as well. When you examine these patients, you find that they have a large epithelial defect, and oftentimes this is best demonstrated if you use a drop of fluorescent and blue light. So if you put a drop of fluorescent, which is usually available in casualty, it's a non-toxic yellow colored dye. You put a little drop of it and then use a blue light, you'll find that the epithelial defect shows up quite nicely. You also tend to have a white infiltrate in the stroma, and sometimes you can have pus collecting in the front of the eye, which is called as a hypopia. So what do you do with these patients? It's important to send these patients to see an ophthalmologist ASAP. Obviously, the ophthalmologist will do a corneal scrape and then start the patient on intensive topical antibiotics. And so depending on how much space you have in your wards, you can set them up in an isolation cubicle and continue with hourly drops until the situation improves. It's very important for us to know what bug is affecting the patient, or at least have a clue. Like, for example, if you have a dendritic ulcer, then you know that it's probably caused by a virus, and so on. And particularly if your patient then is a contact lens wearer, then you can assume that it's probably related to acanthamoeba or some sort of, or if a patient is a diabetic and so on, then you should consider fungal as well. So when I used to work in rural India, there used to be a situation where quite a lot of patients who were farming, etc., who had injuries to the eyes, had first aid treatment with breast milk, and that is known to cause fungal keratitis as well. I think the practice might have changed right now, but so you need to consider all possibilities when you see a patient with a corneal ulcer. Here are some examples of what you tend to see. Here is an infiltrate, so it's a white area within the cornea, and you can see how the white blood cells in the anterior chamber have layered to form a hypopia. This is to be distinguished from what we saw before, which is blood in the anterior chamber, which is called as hyphema. And here is an unfortunate situation. This is a young lady who went to sleep with a contact lens and then developed a problem which she ignored for a few days. And this has resulted in extensive corneal sloughing. And you can see how the hyphema fills almost half of the eye. And unfortunately, this eye had to be eviscerated. And she was in her 20s, which is very unfortunate. So for every contact lens wearer who's listening to this lecture, and for every other person whom you are going to meet who wears a contact lenses, ask them to be extra careful. If they do have any problems after wearing the contact lenses, it's important for them to go and see an optician or an ophthalmologist to confirm there isn't a problem. So let's move on to a more situation with much more gravitas, which is called as endophthalmitis. And endophthalmitis is usually a situation which happens post-operatively, either caused by staph or strep and other organisms as well. They result in redness, pain, reduced vision, and usually happens about 3 to 5 days after the actual operation. Patients present with quite a lot of conjunctival injection, anterior chamber activity, so you see a lot of white blood cells there, and you see a hypopyon like we saw in the other picture. When you try and look into the back of the eye, there are lots of white blood cells studding the vitreous, so the view of the fundus is going to be hazy. So a view of the fundus is looking into the retina. What do you do with these patients? Obviously, they need to be seen by an ophthalmologist. The ophthalmologist would try and take a little sample from the front of the eye and possibly from the vitreous as well to send to microbiology to find what is causing the problem. And at the same time, once the biopsy is taken, we instill some intravenous antibiotics, usually a combination of 2 antibiotics. And we also start the patient on intensive topical antibiotics and try and give them some systemic antibiotics as well. And once the infection is under control, then we start them on some topical steroid eye drops to make sure that the inflammation caused in the eye does not cause permanent structural problems. Let's move on to one of the structural problems which we discussed before in the initial slides, acute angle closure glaucoma. The acute angle closure glaucoma is a rather very acute condition, but you need to remember that the patients might present not to an ophthalmologist, but can present to any casualty. So they complain of a rather severe headache, and they can present with significant nausea and actually be sick or be vomiting all the time. So when you have these type of presenting symptoms, if the patient does not have a fever, just feel and make sure that they don't have a temperature. And if they're otherwise okay and the health has been reasonable, then first thing which you need to do is to just quickly check the pupils. I'll tell you why I'm asking you to do that when I show you the pictures next. But usually the causes of acute angular glaucoma are hypermetropia, which means patients are farsighted, which is the opposite of nearsighted. So this is the opposite of myopia if you're hypermetropic, or sometimes if you have a cataract which has become extremely mature and is swollen up, then that can cause an acute angular closure glaucoma as well. Patient presents with pain and headache and nausea and can sometimes be sick as well. So the signs which you tend to see is that the patient's vision is reduced on that side, the eye is congested, there's a lot of corneal edema, and this is a rather classical sign where you have mid-dilated pupil. If you have the proper equipment, you can actually check to see how the drainage angle is. We use a lens called as a gonio lens, and that will demonstrate that the drainage angle is closed. So when you refer these patients to an ophthalmologist, the things which we tend to do is we give them systemic acetazolamide, which is sold as Diamox in this country. And we also give them mannitol, which is a substance which given intravenously shrinks the vitreous, and therefore it improves the drainage angle. So we start these patients on pilocarpine, which is a drug to reduce the pupil size, and also give them beta blockers and other agents to reduce the pressure. Once the cornea is clear enough, then these patients need to have what is called as an iridotomy, and this is usually delivered through a laser called as neodymium yttrium aluminum garnet, or Nd:YAG laser for short. And we make a little opening in the iris, which creates another pathway for the fluid to come into the front of the eye and get drained. If the angles are closed and been closed for long enough, then the patient might end up needing a surgical iridectomy, which is quite complex, taking such patients into theater. So these are some pictures about the mid-dilated pupil, which I talked about as a classical and important sign of patients with acute angular closure glaucoma. So when you have a patient who complains of pain and also has systemic features like headache and vomiting, and when you examine their eyes and find that one pupil is fixed and dilated and not working, but the other one is quite okay, then you do need to suspect an acute angular closure glaucoma. Let's move on to retinal detachment. So retinal detachment is when the light sensitive area layer in the back of the eye, which is the retina, peels off from the choroid to which it is usually plastered to, and that is because of a retinal tear. So if it happens because of a retinal tear, it's called as a regmatogenous retinal detachment, and this is the commonest type of retinal detachment. There are other types of retinal detachment, including exudative and so on, and another one is tractional, but that's not what you tend to see often. Regmatogenous retinal detachment is what patients present with sudden vision loss. It usually happens among the patients who have crossed the age of 60 when they have a posterior vitreous detachment, but it can happen a bit sooner in younger myopes, and also if they've had trauma to their eye. So the symptoms which they present with would be flashing lights. So they'll see flashes in the corner of the eye. Usually when they're sitting in a dark room, some patients report as if there's a car flashing by, and it keeps happening on the same side, and it's associated with quite a lot of black or gray floaters in their vision. And if they do have a retinal tear which progresses onto a retinal detachment, then they can have a shadow or a curtain which crosses across the vision and is usually painless. And it doesn't move, it doesn't get better, it's always there. When you examine these patients, you do a confrontation visual field test. So asking the patient looking straight into you, you show fingers at all 4 quadrants to see if they can see the number of fingers you're holding up. And if they have an area where they can see this curtain, they might not be able to count your fingers there. So it's a very important, simple test to demonstrate how the visual field is. If the vision is reduced significantly, if the detachment has come into the center, which is the macula. So what happens if you don't treat these patients? It can lead to complete blindness if not treated in a timely fashion. And once macula is detached, then unfortunately, we cannot restore the vision fully. How do we manage these patients? We do types of surgeries, an operation from outside the eye, which is called as a scleral buckle, and another operation where we make 3 little ports go into the back of the eye, remove the vitreous jelly and put the retina back. It's called as a vitrectomy. So here are some examples of what you tend to see. So this is a large horseshoe tear. It's called as a horseshoe tear because it looks like a horseshoe. And you can see how the retina has peeled off. So this is what happens, you see. So when there's a hole in the retina here, the vitreous jelly moves through the hole and slowly strips off the retina. It's almost like you peel off wallpaper from the wall. So let's move on to some other medical problems. So these conditions which I'm going to discuss next are more a reflection of a systemic issue rather than a problem starting within the eye itself. So what is a central retinal arterial occlusion? It's a painless cause for sudden loss of vision and is usually caused because of an arthroma or an embolus, which can arise from the cardiac carotid artery, or it can have a cardiac origin as well. Sometimes if you have very high raised intraocular pressures, then it can cause central retinal arterial occlusion as well. Some patients present with loss of vision for small periods of time, which is called as amaurosis, and usually the vision loss is painless and sudden. So when you examine these patients, there's a marked vision loss. There is a relative afferent pupillary defect. So what is a relative afferent pupillary defect? When you move the torchlight between the eyes, you'll see that one pupil is acting quite briskly, but when you move it to the other side, which is affected, the pupil, instead of contracting, it actually dilates. So you move it this way between the eyes, and you find that when you move the light onto one eye, the affected eye, if the pupil dilates, that's called as a relative afferent pupillary defect, and it's a very important clinical sign. When you look at the eye, I'll show you that you can see a classical feature which is called as a cherry red spot. Sometimes you can have blood vessels which look cattle trucked, or it looks like they're segmented retinal blood vessels, and very rarely you can see an embolus as well. If you have a patient who comes to you and you've identified that they have a central retinal arterial occlusion and they're within 12 hours of when the symptoms started, then there are a few things which you can do to try and restore some of the circulation back. And that includes asking them to breathe into a paper bag, rebreathe into a paper bag. So what that does is it causes a bit of vasodilation, which might help, and also some pressure around the eye. So the pressure should not be for more than 6, a count of 6. So you press for 6 seconds, let go, leave it for 6, and then press again. So that's what you do. So by doing that, you're reducing the intraocular pressure, and you might be able to re-establish the circulation in the back of the eye. If the event has happened 12 hours or before, then unfortunately, there isn't much scope for any vision coming back despite whatever you do. Some brave doctors also put a needle into the front of the eye called paracentesis to let some fluid out to dramatically reduce the pressure. Well, you have to remember that when you have this, because it's a manifestation of a systemic problem, it's important to do a ESR, CRP, and full blood count. And this is because you need to rule out a condition called giant cell arteritis, which we'll discuss in a minute, which is more common among Caucasians, but can happen. I've seen a few patients in India also, and that can present with the CRAO. And if the patient is in need of a blood thinner, then you can consider things like aspirin. So I was talking to you about the features of the central retinal arterial occlusion. When you look into the back of the eye, you can see how the fundus looks to be quite white, except for a small little red spot over here. So this sign is called as a cherry red spot and is a classical feature of any patients who present with central retinal arterial occlusion. So this is something to look for. So let's move on to anterior ischemic optic neuropathy. Anterior ischemic optic neuropathy is when the blood supply to the optic nerve is affected significantly. It can either be of an arteritic type, which is caused by giant cell arteritis, which is a dangerous condition, or it can be non-arteritic, which is usually caused either by arteriosclerosis or atherosclerosis. So what are the symptoms? Both of them can present with sudden painless loss of vision. When you examine these patients, you'll find that the visual acuities are significantly reduced. They also have altitudinal field effects. So remember when I was talking to you about how to test for visual fields, you get a patient and you put the fields in 4 quadrants. So when it's an altitudinal field effect, the patient will have a loss of lower half of visual field or upper half of visual field. And that is pretty typical of ischemic optic neuropathy, and it's called as an altitudinal field effect. These conditions tend to evolve and it will result in the optic nerve becoming weaker, ultimately resulting in optic atrophy. And the other thing to notice is that in the acute stages, you'll have a swollen disc, usually on the side, which has been affected. So again, you need to make sure that this patient does not have giant cell arteritis. And there is a reason for that, which I'll come to in a minute. Then you screen for hypertension, diabetes, and other systemic issues also. So this is how an anterior ischemic optic neuropathy patient would look. You can see that the edges of the optic nerve have become a bit fluffy. It means that the optic nerve is swollen, and you can see how it's pale as well. And when you do a visual field test on these patients, you'll find that they are unable to see one half of the visual field. So this is a classical altitudinal visual field defect, which is typical of a patient with ischemic optic neuropathy. So we'll move on to giant cell arteritis. This is quite a significant condition, which tends to, it is a cause of vasculitis of medium sized blood vessels affecting people over the age of 60. So the classical features are temporal headache, scalp tenderness. So the scalp tenderness can be so bad that the patients can't even brush their hair back because it's so tender there. They oftentimes complain of pain on chewing. They can't eat things like chapati, etc. They generally feel a bit unwell, and they say that sometimes they feel depressed as well, and they have a history of some weight loss, etc. And in the eyes, they can have diplopia and sudden loss of vision. So when you examine these patients, you gently tend to see if they have a prominent superficial temporal artery, and you feel for tenderness around there. These patients can present with the sixth nerve palsy in addition to the optic nerve problems which we discussed before. Why is it important to make a diagnosis of giant cell arteritis? It is because it's a disease which can kill within a few weeks. It can snuff out the other eye in 70% of patients if they're not treated appropriately. So it's very important to make the diagnosis. I know that it's not very common in India, but it's also important to make sure that you do rule it out. So what are the features you tend to see in these patients? You need to make sure that they check the ESR and CRP. You admit these patients and start them on high-dose steroids, which is usually an intravenous methylprednisolone pulse, which is usually given a gram over 3 days. We also get them to have a temporal artery biopsy. It's unfortunate that if you do make a diagnosis of giant cell arteritis, these patients are likely to be on steroids for the rest of their life, which is a double-edged weapon. In addition to controlling the inflammation, it can cause quite a lot of other issues, including depression, break your bones, etc. So you need to have proof that it is giant cell arteritis, and that is usually obtained by doing a temporal artery biopsy. So you remember I was telling you about palpable temporal, superficial temporal artery, which can be tender, and this is how it generally tends to look. So let's move on to papilledema. So papilledema is a condition which is caused by raised intracranial pressure. So usually it's associated with the space occupying lesion, and you can also have a condition called as IIH, or idiopathic intracranial hypertension, which was previously called benign intracranial hypertension. So benign intracranial hypertension, or IIH, is usually associated with, it's usually seen in females, but it can happen in men as well. And it's usually middle-aged, overweight patients. But the most important thing here, when you see a picture like this, is to make sure that you exclude a space occupying lesion. Again, one of the other things which can present with swollen discs is accelerated hypertension, uncontrolled or undiagnosed systemic hypertension. And you need to make sure that these patients, first thing they do, if you think of that, would probably be to check the blood pressure. These patients can sometimes be asymptomatic. They can have an occipital headache and can present with transient obscurations of vision. When you examine these patients, you'll find all of these features of hypertensive retinopathy, which include cotton wool spots. So it's literally like small little pieces of cotton lying on the retina. And you can have retinal hemorrhages, optic disc swelling, and sometimes these patients can present with significant problems causing encephalopathy as well. So what do you do with these patients? They require an urgent admission. I don't think very much that I'm sorry, this particular slide might be out of time. I don't think they use sodium nitroprusside anymore, but there are other antihypertensives which you can use. It's very important to try and find out what the cause for the hypertension is. If there are some secondary causes which include renal artery stenosis and pheochromocytoma, which need to be ruled out. So this is a picture of a patient with accelerated hypertension. Here you can see the disc margins are swollen and they're irregular. The disc itself is congested. You can see quite a lot of exudates here. And so these are called as hard exudates. Hard exudates are more yellow. And we talked about cotton wool spots. They are more fluffy and white. You can't see them here actually. So let's move on to the last part of the lecture today. And this includes eye movement disorders. The causes of eye movement disorders can be manifold and can be because of brainstem disorders, cranial nerve palsies, and the cranial nerve palsies can in turn be caused by hypertension, diabetes, and sometimes surgical causes such as an aneurysm. You can have other conditions like myasthenia gravis and certain muscle diseases which can cause movement disorders as well. So the symptoms are usually diplopia, which is double vision, and there are different types of diplopia you can get. So in third nerve, which controls quite a few muscles, you can have a complicated double vision. In fourth, you tend to get a vertical double vision, and in sixth, it's usually a horizontal double vision. There are other features associated with third nerve, which includes a droopy eyelid, dilated pupil, etc. And it's quite important to look for all of these signs because you might actually be saving the patient's life. So let's look at what happens with third nerve. You can have a partial or complete ptosis, which is droopy eyelid, limitation of the ocular movements in all directions of gaze, except for abduction. So that is, the lateral rectus is controlled by the sixth nerve, and therefore that's responsible for moving the eyeball outside. So my left eye, when it moves outside, it's my sixth nerve which is moving it outside. Whereas every other movement is controlled by the third nerve. So when the third nerve is paralyzed, it means that the sixth nerve would deviate the pupil outside. So if you have a droopy eyelid, which you're lifting up, and you find that the eyeball is actually looking that way, then you can almost certainly make a diagnosis of a third nerve palsy. And when you do that, if you find that the patient has a dilated pupil, then that means that this patient has an intracranial aneurysm, which becomes a neurosurgical emergency. So that's why you should look for, if a patient presents with a droopy eyelid, they might not actually complain of double vision because that lid is dropping and stopping them from having double vision. When you lift the lid up, they might complain of double vision, and you find the eyeball is actually rolled outside and the pupil is dilated, you need to think about this possibility. You might save a patient's life there. So if it's the fourth nerve which is affected, usually there's a head tilt to one side. There's a limitation of depression of the eye when looking down and in. It's a slightly more complex situation, and these patients would need to have further evaluations and so on. It can be caused by things like trauma, etc. Sixth nerve, as we discussed before, the sixth nerve is responsible for abduction of the eye, so abduction of the eye. So when the sixth nerve is affected, it means that the eye will actually be looking inwards. So sixth nerve can be caused by various other problems as well, including diabetes, etc., and that will need further imaging. When it's brainstem and muscle disease, you'll find that they don't actually follow these typical patterns, and they're very more complex eye movement disorders. Let's look at this feature. So I told you about how they present with a droopy eyelid. This patient is not going to complain of double vision because this has stopped them from having any vision in this eye. When you lift the lid up, you can see how the lateral rectus is still intact, so it's pulled the eyeball outside, and therefore this is a typical feature of a third nerve palsy. Here are some other features which you expect to see. So again, this eye has been looking in all the 9 cardinal gaze positions. So you're looking up and to the right, over to the right, down to the right, and so on. And you can see how the left eye is not making any movements at all, except when the patient is looking to the left, because that muscle is still intact because of the nerve supply from the sixth nerve. So when you have a third nerve palsy, it's very important to have a full neurological examination, including checking the blood pressure and blood sugar. You need to get these patients to be seen by a neurologist and a neurosurgeon and also an ophthalmologist. If you tend to do a cerebral angiogram to look for intracranial aneurysms, and if they do have an aneurysm, they will probably need to have a clip done, which is quite a complex brain surgery, To reduce the diplopia, we can put a patch over the eye, just close the eye with a cotton pad, or you can give them something called as Fresnel prism. So these Fresnel prisms are just a stick-on little prism which will correct the position of the eye to a certain extent. When it's become long-standing, then you can consider things like botulinum toxin, Botox, and possibly surgery as well to correct the position of the lid. So here is an example of an intracranial aneurysm which has been clipped. You can see that there, and that's a cerebral angiogram. And this is a patient who's got a sixth nerve palsy. So we said that the sixth nerve is responsible for rotating the eyeball outside. So this patient's been asked to look towards this little pointer over here. His left eye is able to do that, whereas his right eye is not able to do that. So that's a typical feature of a sixth nerve palsy. So I think we come to the end of the lecture, and I hope not all of you have fallen asleep. Thanks again for this opportunity.
Thank you so much, sir, for that excellent talk. Extremely grateful for that. Over to Satish, sir, for the moderation.
Yeah, it was a wonderful presentation, Dr. Ramesh. Quite a comprehensive one on a vast topic. So for those of you who listened to the talk, really it would have covered so much of ophthalmology, because unlike another topic, it doesn't deal with one subspecialty. This has gone across almost all the subspecialties we have in ophthalmology, whether it's cornea or retina or oculoplasty or strabismus. So you would have gained quite a bit from just this talk. Since the topic is quite vast, we'll not go into individual topics here, but maybe I can just start off with asking Dr. Ramesh a question regarding non-accidental injuries, the shaken baby syndrome. You've worked in both India as well as in the UK. And why do we not see so many of such cases here? Is it just a lack of awareness of the society, or do you think genuinely these cases are less here as compared to the West?
That's an excellent question, Dr. Thomas. I think it's more related to cultural aspects. And I mean, like when I worked in India, which is going back about 22 years, I didn't work in a retinal unit where we saw these patients on a regular basis. But in the type of setting I work here in the UK, this is probably something I tend to see one or two of these patients every week, really, which is very unfortunate. I think the main reason, as I said in the lecture, is that they're usually a single parent who was not really expecting a child. They don't have the physical, financial means of supporting the child, so they're under a lot of duress and so on. But the most important thing is that they don't have the family setup where there's someone else who's able to care for the child. Whereas in India, we all still have some connections, although most of us are perhaps moving out of nuclear family setups. We still have a relative who can come in and chip in and so on. And therefore, the frustration around bringing up a child is probably lesser. This is my assumption, and I think that could be it.
Yeah. Okay. I think I'll just sum up for especially for the students who listen to this topic.
Just an information, sir. Many of the students had some issues with their Zoom apps in the hostel, and they have all gone live in YouTube. That's why we don't have the crowd here in the Zoom room. Just to inform that we have more than 30-40 students who have attended the session in the YouTube, sir.
Yeah.
Yes.
Yeah, since you students are not so much exposed to these cases in a practical setup, you may not right now be engaged with how to deal with these patients, but a topic like this is so very important even for your exams. because you just take blunt trauma, it covers almost, you would have got some, say, about 10, 15 short note topics covered in blunt trauma alone here. And similar, so a talk like this is extremely important even from that point of view. In trauma, it's as much as what to do, it's also important what not to do. I'm sure you would have taken a lot of carry home messages from this. It's most important to restore the globe integrity if you have a perforated globe, because that is what protects. The eye is made in such a way that God has left all the important structures well protected inside. And if that is compromised, then your first job when you see such a patient is just to restore the integrity of the globe, just close it. And all the rest of the things can be managed later if this is done. But if this is not done, then that eye is gone. Similarly with chemical burns, Sir just told you how important it was to wash that eye with just water or saline for about 30 minutes. A simple act like that is the difference between an eye that has vision and an eye that is going to be permanently blind. My postgraduate thesis in AIMS was on alkali burns. And I have a landmark paper on that thesis in ophthalmology. This is because the alkali especially, and acid to a lesser extent, damages the stem cells of the corneal epithelium which are located at the limbus. So once that damage is done, then there's nothing you can do to restore that. All the stem cell transplantation and limbal transplantation and all that may or may not succeed. And it's a big step. But if you can just try and prevent that by copious first aid management, if you are the first person that the patient sees, that patient has been lucky. So a lot of tips like that were given during this talk. CRAO management, how do you do that? So I hope that you have gained a lot from this. If you can just go back and flip through your books quickly, you saw a lot of wonderful photographs. So go through your books quickly, just turn your pages on the relevant topics that you saw, and much of it that you heard today, you will be able to retain. So once again, I want to thank Dr. Ramesh for a wonderfully done presentation, very comprehensive. Yeah, thank you so much. Over to Dr. Jacob.
Ramesh sir, I would like to thank you from the depth of my heart and on the behalf of our institution. It was a great privilege to listen to you. Actually, we are getting messages on WhatsApp from students who have listened on YouTube. They are really, really thankful to you for that amazing session. And yes, sir, we look forward to many more sessions from you in the future whenever you get time, and we would love to engage with you further. So, and also it was really, really nice to get to know you, sir. Such a pleasant person, and it's really a joy to have known you, sir. Thank you, sir.
Well, it's a privilege. I thank you from the bottom of my heart to give me this chance to connect with my own fellow students and my own country, because it gives me great privilege to have this conversation with them. And I hope the talk was helpful. I look forward to interacting with you in the future. Thank you.
Thank you so much, sir. Thank you so much. Definitely. And Satish, sir, I think now you have to hit the sack. You must be very tired.
Yeah.
Thank you so much for admirably moderating the session, sir. And if there are no more questions, I think we can wrap up this session. Thank you so much, everybody. And thanks to the participants, especially all of our students who have come to YouTube due to issues with the Zoom. And thank you, everybody. Have a pleasant evening. Goodbye.